table. क्या आया था अभी इसको प्रॉब्लम तो फाइंड आउट हो गया है भाई इधर 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 ग्लास ग्लास भी रख हाँ हाँ टिश्यू भी रख ये बस आएगा इवन ग्लास वाला बोल the main one the side one this is working main one is working they're checking the video it's still playing don't know we can't जो लाइट है ना लाइट के ऊपर ही रहेगा बाकी चल रहे हैं बट में करंट समझ रहा है प्रॉब्लम हो जाएगा क्योंकि अभी अपना बना ना उसके बाद उसको स्प्रे तो किया लेकिन अभी ज़्यादा नहीं कर सकते अपना ज़्यादा हो गया ना जस्ट अभी शुरुआत ही अपना हुआ है और कुछ किया ही नहीं तो चालू कर दिया क्या हो गया यहाँ पर या तो Yeah, they have the control. They have the control. मुझे कंट्रोल देने बोलो होते हैं ना they have the control. No, no, I'm not. They have the control. They have the control. दूसरा भी डेढ़ पूजा अलाउ सारे जाना है वीडियो कंट्रोल में करता है पोडियम सिस्टम अभी जो वीडियो चलता है आप ही कंट्रोल कर जो प्रेजेंटेशन आता है पोडियम सिस्टम पे कंट्रोल It's not moving. Not moving. I'll be.
ठीक है, अभी आप यहाँ से कंट्रोल कर सकते हो ओपीसी को, ठीक है। कुछ और मत आप ओपन करना, बस ये स्लाइड ओपन रहेगा। हाँ,
हॉस्पिटल डे ऑपरेशन का स्टार्ट
हाँ, एक मिनट।
तो पूरा मुझे कंट्रोल देगा मुझे।
हाँ, यहाँ से अभी सारा कंट्रोल है, ठीक है। सेशन सेशन 2, वेट वेट वेट, सेशन 2 हॉस्पिटल डे मुंबई।
बेटा और लैपटॉप पर जरा ब्रेक दे दे, कनेक्ट कर दे। तर मी काढलं तर ते पण जाईल.
ओके मैम, ओके ओके। ठीक है, अभी आप यहाँ से नेक्स्ट करोगे, ठीक है।
पूरा चेंज।
ठीक है, हो ना। अभी मैं सेटिंग बता रहा हूँ। हाँ, अभी वीडियो वीडियो प्ले करना है, साउंड वीडियो
साउंड आ रहा है क्या? साउंड आ रहा है क्या?
पूरा चेंज हो रहा है। इधर से कंट्रोल कर दूंगा।
मैं रुकता हूँ सर यहाँ।
इधर से कंट्रोल।
ओके
इधर से कंट्रोल कर दूंगा पूरा।
उधर माउस डिस्कनेक्ट करने को ना।
उधर उधर का माउस डिस्कनेक्ट कर। उधर का माउस डिस्कनेक्ट
नहीं, डिस्कनेक्ट नहीं रहने तो अभी क्या करना है?
वेट करना है, कुछ नहीं करना।
वीडियो कब प्ले करना है मुझे बताइए। वेट वेट, शेयर द स्क्रीन। का प्रेजेंटेशन है ना, इनका स्लाइड है। हाँ, वो लगा देता हूँ मैं।
Good morning, esteemed dignitaries, guests, and colleagues. It is my absolute honor to welcome you all to the EBM 2026 Hospital Day Oration session at the Tata Memorial Hospital. I have only one disclaimer, and that is that apart from that AI generated image, everything else that I say is going to be non-AI generated. So it is written by me. Since the last 24 years, cancer care providers across India and beyond gather in this August auditorium with our phones on vibrate mode, if I may add, to celebrate the profound impact of evidence-based medicine on cancer care and to catalyze the adoption and propagation of the same, one small evidence-based step at a time. To set the stage for the oration on the Foundation Day, let us first take a moment to reflect on the foundation of this institute. The Tata Memorial Hospital was inaugurated precisely 85 years ago on this very day, 28th February 1941, by the then Governor of Bombay, Sir Roger Lumley. In his inaugural speech, Sir Lumley proclaimed, "The name of Tata is known throughout the world as a house of great industrialists and a family of great philanthropists. But of all the philanthropic projects connected with that name, none would attain a greater importance or reflect greater credit on its founders than the Tata Memorial Hospital for Cancer. This hospital is the first large contribution of India to the international fight against cancer." And his words indeed have been proven prophetic. The hospital was created by the generosity of Sir Dorabji Tata in the memory of his late wife, Lady Meherbai Tata, who expired of leukemia in 1931. Sir Dorabji himself unfortunately passed away in 1932, but such was his determination and commitment to the cause of cancer care that the trustees of the Sir Dorabji Tata Trust immediately took upon themselves to create India's first comprehensive cancer hospital. The Tata Group, which was then headed by Sir Nauroji Saklatwala, reached out to the American cancer specialist Dr. John Spies, one of the first doctors trained at the Memorial Sloan Kettering Cancer Center, and invited him to visit India and helm the project. Now remember the context. This was the early 1930s. When all of this action is happening, there was the shadow of the Great Economic Depression still looming over all industrialists, and which was followed soon by the rumblings of World War II. And yet, Sir Dorabji Tata Trust made a capital grant of rupees 30 lakhs, a huge sum in those days, to fund this hospital. The plan, though, wasn't just to create a building, but also create a cadre of world-class dedicated cancer specialists. Accordingly, the Tata Trust sent 4 young Indian doctors abroad for training in cancer care. Dr. J.C. Paymaster, Dr. Ernst Borges, Meher Homji, and DJ Jassawala. All familiar names for us working at Tata. And this was during the World War II. So despite the risks of traveling amidst the World War, these doctors were happy to travel to Europe and to US, hone their skills, and then return back to serve the country. At the time of inauguration, the hospital included the departments of surgery, radiophysics, radiology, anesthesia, and pathology. And except for 2 American surgeons, all the staff were entirely and proudly Indian. This was the first such comprehensive cancer hospital, not just in India, but across Asia. No wonder then, Sir Sorab Saklatwala, who spoke at the inauguration, called TMH a labor of love and a temple of learning. And it is this passion and culture of service to the nation and its people that we celebrate today on the Foundation Day. The Evidence-Based Management of Cancers Conference has been going on since 2002 to continue this legacy of service, education, and research. The EBM team has created a short video clip that offers a glimpse into the rich history of the EBM conference and the Hospital Day Orations. It highlights several milestones that reflect the stature and the impact of this meeting, including the fact that 2 Nobel laureates have previously graced this stage. I invite you to watch it closely. It is both a tribute to our history and a reminder of the standards that we continuously strive to uphold and further.
There's nothing as important to human beings, we should readily agree, as our health. People across the world even greet each other through a quote-unquote salute. Salute is a word that literally means being in good health. By saluting each other, we wish each other, at least in our choice of word, good health. Not more wealth, not more opulence, not even more happiness, but better health. Public health care, we need more devotion by the state, and in a democracy, the people ought to demand it rather than be silent. That's really the biggest culprit here.
I think that the fact that you have this conference every year, you've had it for over 20 years, this is really important. I think that the whole area of science, data, evidence that should drive our policies is something that we should not underestimate, and something that I'm so glad that this institution has been doing for many years and continues to commit.
This EBM, evidence-based management for cancer, it brings a range of hopes to the people. I always tell Tata Memorial Center and all of you working in the center are the jewels in the crowns of atomic energy.
Well, after that inspiring video, I'm sure that none of us can wait for today's proceedings to begin. So let's do so right away. We are indeed fortunate to have in our midst a galaxy of stalwarts, and I would now invite them on stage to grace this occasion. As they move to the stage and take their seats, let us extend our warmest welcome with a big round of applause. I first request Dr. Sudeep Gupta, Director TMC, to accompany Professor Vincent Gregoire to the dais. I invite Dr. C.S. Pramesh, Director TMH, to grace the stage. Dr. Pankaj Chaturvedi, Director Actric. Dr. Rajendra Badve, Professor Emeritus and former Director TMC. Dr. Shripad Banavli, former Director Academics. Dr. Satyajit Pradhan, Director TMC Varanasi. Dr. Ashish Gulia, Director TMC Mulanpur and Sangrur. Dr. Siddharth Laskar, Director Academics TMC. And Dr. Rajesh Dikshit, Director Center for Cancer Epidemiology. I now invite Dr. Sudeep Gupta to felicitate our orator for today, Professor Vincent Gregoire, with a floral tribute. I now request Dr. Sudeep Gupta, Director TMC, to deliver the welcome address.
Thank you very much, Akshay. Good morning, ladies and gentlemen. This is the 24th EBM meeting. And as Dr. Soumya Swaminathan said in her oration last year, there must be something right about what we do when we do it year on year for the 24th time. And the fact that this hall is full is a testament to the utility and impact of the EBM meetings that we have had for the last 24 years. Most of you have noticed that the auditorium is renovated, but let me assure you that the soul remains the same. Our orator for today just told me that he was in this hall 24 years ago when Dr. Dinshaw invited him for a meeting, and he remembered the old auditorium. I also want to say that this is a place where, for the past many decades, a lot of individuals, not only during the conferences that we have, but during the Thursday morning meetings that we do, during numerous other deliberations that we do, we have agreed and disagreed. But then we have gone out of this hall having the good of our patients in our minds and in our hearts. 28th February, Akshay just mentioned, is the birthday of Tata Memorial Hospital. I would also like to share with you that 28th February is also the National Science Day in India. And the reason that it's a National Science Day is because C.V. Raman announced the discovery of his Raman effect on 28th February 1928. So this day is special for two reasons. Going forward, I think we all need to move forward together. There is no one institution or one individual or only one group of individuals who will make an impact. All of us have to together do it. There is innovation, research, advancements, better treatments, more application of scientific innovation to the treatment of cancer all over the world. And we are very fortunate that we have such a learned set of individuals who are the faculty members, but also the delegates here. And we will not forget the fact that we are here not only to learn for our own sakes, but we are here to learn so that we can apply to the individuals who come to us for treatment. And with that goal in mind, I'm sure that we will assimilate all the learning, all the wisdom that will be here for the next couple of days, or it's already been there since yesterday. And I'm sure that all of you will enjoy the proceedings. You will go back more enriched, again, not only for ourselves, but also for our patients, and primarily for our patients. So before I end, I would like to thank all the faculty members, both from India and from outside, who have traveled long distances to be here. There is nothing like a meeting in person. Although we have these online meetings, most of us know how distracted we are when we sit in those online meetings. This is a place where we will not only listen to talks, where we will not only ask questions in the hall, but we will interact with each other. We will make networks. We will create new friendships, and hopefully that will move the entire field forward. I would like to thank all the delegates who have come from all over India. I'm told that the registration for this year's conference is overwhelming, also because of the fact that head and neck cancer is unfortunately still the most common or one of the most common cancers in India. We will, as we move forward, as our country becomes more affluent, more developed, we move up the human development indices. We will hope not only to treat cancer better, but we will also hope that the incidence of some of these cancers comes down. And of course, head and neck cancer is a prime example of a disease where we hope that we will not need to treat as many patients as we do today, at least in India. So thank you all very much. And my grateful thanks to everyone who's in this audience. Thank you.
Thank you so much, sir, for your inspiring and insightful words. I think the story of this institute and this auditorium is long, it's illustrious, and I think we are all writing the next chapters by continuing to contribute. Let us now take a glimpse into the vision, the thought process, and the behind-the-scenes hard work that went into organizing EBM 2026. For that, I would like to invite Dr. Pankaj Chaturvedi, the organizing chairperson EBM 2026, Dr. Anuja Deshmukh, organizing secretary pre-conference workshops, and Dr. Shiv Kumar, organizing secretary EBM 2026, to speak about the head and neck track, starting from Dr. Chaturvedi.
So, good morning. So, I'm the chairperson for the conference, and I say that I made a huge contribution to make this program success by not interfering in what they were doing. To an extent that I have little contribution in making this a success. And I must say that as we, transition, and I think Pramesh, myself, and Ajay, perhaps we are the three last samurais existing in Department of Surgery, because many of our colleagues have moved to the greener pastures, and we are still here safeguarding and nurturing the mother pasture. So I'm so happy that the newer I'm so happy that the future of head and neck oncology in the country is bright because we have so much of attendance, and the craving for learning evidence-based medicines also shows that there is a better evolution. The second is that we are so heartening. It's so nice to see that the young generation is better than the older generation, and I can see the clear transition that we are moving towards the better head and neck oncology group. We are moving towards a better head and neck DMG, and that also allows us to retire gracefully. So now I give the mic to our two colleagues who actually should get the credit, and all the wrong things that has happened, including technical problem that Vincent you faces because of me, but all the good things is because of them. Over to them.
Thank you, sir. So, distinguishing dignitary on the dais and off the dais, it gives me an immense pleasure and the satisfaction to acknowledge the successful conduct of the pre-conference workshop at Tata Memorial Hospital on 26th of February. We conducted 4 at Tata Hospital and 2 at ACTRAC. It was organized by Dr. Shiva on the conservative laryngeal surgery, Dr. Swapnil Rane on digital pathology, Dr. Sandeep Gurav on dental implants, Dr. Sarbani on a sinonasal tumor radiotherapy, Dr. Archi Agarwal on the radioiodine, Amit Janu on thyroid and skull base radiology. And it was attended by many delegates, close to 300, and it was conducted by the international faculty and national faculty. I thank all the head and neck DMG for giving us the opportunity to conduct this pre-conference workshop. Thank you very much.
Good afternoon to all the dignitaries on the stage and off the stage, and all colleagues and friends. I stand here with a lot of gratitude, and and also with a lot of happiness with the overwhelming registration and success that we have had with this conference, which exceeds both in-person and online registrations exceeding 1,400. And as we all know, the head and neck cancer remains the most common cancer, as was mentioned by Sir. And our aim while designing this program was very simple, though ambitious, to focus on every aspect of head and neck cancer management that could improve the treatment outcomes of our patients. So we gave a head and neck 360-degree experience to our patients, just to put it in simple words. And the unique advantage this year was that there was a singular focus on head and neck cancer. This was the only track. We had all the auditoriums to be used to the fullest, which we did. And the response, as I said, was overwhelming, not just in terms of registration. Also, we had 56 abstracts that were submitted, which is being judged, and the best two will be announced tomorrow. And here, though there's an official vote of thanks, I would like to just thank the administration, of course, and the entire head neck DMG for giving me this opportunity to organize this very conference. And most importantly, the residents and fellows who worked behind the scenes for the entire conference. So I definitely would want to thank them. I'd like to thank the CRS and other support staff, and thank you all for your attention. Thank you.
You know, when I heard the term mother pasture, had this image of, cows with doctors' aprons grazing in lush green fields somehow. But one thing I would say, sir, is that, Mother Teresa, Mahatma Gandhi, Nelson Mandela, Albert Einstein have all said this famous quote: "A great conference without a technical glitch is a figment of imagination." So I think we can be excused for this. Yeah, but thank you so much for, your inspiring words and the hard work. I would now, I'm sure we all eagerly awaiting the oration. So I would now extend my gratitude to all the dignitaries on stage for gracing this occasion. I request them to move to their seats in the front row as we now transition to the oration. I, however, request Professor Vincent Gregoire to continue to be on stage for the oration, along with Dr. Gupta, Dr. Pramesh, and Dr. Chaturvedi to chair the session. I request housekeeping to rearrange the So I think now the stage is set and we do arrive at the much anticipated Hospital Day oration. I request Dr. Sarbani Ghosh Laskar to introduce our esteemed orator, Professor Vincent Gregoire.
Good afternoon, everybody. It gives me great honor and privilege to be able to stand on this stage, which is the Tata Memorial Hospital. And I think yesterday someone said that if you can talk on this stage, you can talk anywhere else in the world. I think this is Dr. De Cruz. But any which ways, I'd like to extend a warm welcome to the dignitaries on the dais, off the dais. And it's a privilege for me to be able to introduce Dr. Vincent Gregoire to all of you. Actually, for us as radiation oncologists, it's not surprising that he is our orator, simply because today the way we do radiation oncology owes a lot to what we've learned from Dr. Gregoire's work. Dr. Gregoire graduated as a medical doctor in 1987 from the Catholic University of Louvain in Belgium. He was both certified in radiation oncology in Belgium in 1994 and obtained his PhD in radiation biology in 1996 after a fellowship at the Netherlands Cancer Institute in Amsterdam and at the MD Anderson Cancer Hospital in Houston. Since his return from the US, Professor Gregoire was appointed as the academic hospital of the Catholic University of Louvain in Brussels, where he was the director of the Center for Molecular Imaging, Oncology and Radiotherapy, and a full professor in radiation oncology and head of the clinic in the Department of Radiation Oncology. From the 1st of May 2018, Professor serves as the head of radiation oncology in the department at Lyon Barrade Cancer Center in Lyon, France. He coordinates the head and neck radiation oncology program where the publication of the consensus guidelines for selection and delineation of target volumes brought him worldwide recognition. To cut a long story short, I'd like to say, if you go through his bibliometry, it's about 97 pages. But just to tell you that he has got more than 356 publications to his credit. His age index is about 77, and the number of citations is about 26,526 to say the least. He has a PhD and a patent too. Now, his publications, to most of us radiation oncologists, it's not unknown, but he has worked right from the beginning in molecular imaging, in introducing an integration of functional imaging into radiation oncology, the contouring guidelines in head and neck oncology as we practice it today in radiation oncology. He has the guidelines for the delineation of the neck nodes, for the delineation of the clinical target volumes in the head and neck area, for the post-operative clinical target volumes. We also know about the various discrepancies that can emerge when we do all these contouring guidelines. And of course, that is what he actually has given us, and that's to say the least. He has served as the past president of the European Society of Therapeutic Radiation Oncology. He also has served on various ESTRO teaching courses, and of course has taught a lot of us about head and neck oncology as we know it today. He has about 20 book chapters to his credit, and he, of course, as I've said, has been a part of the various ESTRO and other training courses. He has also served as a past chairperson of the radiation oncology group of the URTC and of the head and neck group of the URTC. And he was acting chairman of the ICRO report committee on dose prescription specifications and reporting in IMRT. It's indeed a pleasure to all of us, as well as it's a matter of pride for all of us that you are our orator today. Thank you very much and welcome you once again to TMH and to TMC for this great day. Thank you very much and please come for your oration. Thank you very much. It's working.
It's working?
Yeah, it's good to be here.
Distinguished medical directors, dear friends, ladies and gentlemen, Sarbani Ghosh, thank you very much for your nice introduction. I'm deeply honored by your invitation for several reasons. I understood that your cancer center is much longer than anywhere else in the world. So you are probably one of the first real cancer center in the world. And for sure, it is longer than the cancer centers in which I'm working today. As mentioned by you, sir, 25 years ago, I had the privilege to be able to be invited to this similar hall, although before refurbishing by Professor Ding Shao. And so it was my first contact with India. It was my first contact with Tata. And many, many times I came to India and I interacted with Dr. Sarbani Ghosh quite often in making also the guidelines together. And last comment, sadly for me, nicely for you, I've seen over the last 40 years a change in the center of gravity of science in the world. I started in Europe and in the States. We are moving today into India and Asia. And I would like to congratulate you for what you have achieved over the last 20 years. I think I can still speak because my slides are not ready. So obviously there must be something wrong with my slides, although it's made on a nice computer, which is a Macintosh computer. It's maybe I'm irradiating on the system probably, and that makes complex connections. Okay. Okay. So when you asked me to speak, I said, what could I say? because I understood that the audience is not only head and neck, the audience is not only medical doctors. And so I tried to illustrate in the head and neck field what I believe is the way forward in oncology, a mix between clinical aspect, technological aspect, and biological aspect. And the merge between these three, will probably make the future even better than it is today. And indeed, when we did probably treat the first head and neck, it was not head and neck, breast cancer, the first patients with cancer somewhere more than 100 years ago in France by Georges Chicoteau. Look at this attire. I'm not treating my patients like that, I can tell you today. But this was obviously the start of treating cancer patients with ionizing radiation. When I started my training let's say some years ago, let's put it that way, I have to admit that the clinical examination was really minimal, even dismal. I was using a mirror, and I have to confess you, and I'm sorry to confess it, 50% of the time I was not able to see anything. I'm sorry to say so. Maybe, of course, you can see everything because you are head and neck surgeons, or at least some of you. We were not using CT. I've seen the first CT in my life during my medical studies for brain CT, 2 or 3 cm thick CT sections of the brain. We were using planar imaging. So we were basically using the bony structure, and we were transposing the head and neck structures we wanted to irradiate based on the bony structure. We were not able to do 3D planning. We're doing only single one sections planning on a rough basis, I have to admit. And we were treating patients with a good equipment, I have to admit, which was Cobalt 60. Today, in 2026, we all do fiber optic examination for every single patient. We are on top of it, can incorporate your images, your movies that you do during your general anesthesia, endoscopy, and general anesthesia. On a routine basis, we do 3D planning, we do planning with CT, we do planning with MR. We can then delineate properly on a 3-dimensional basis the target volumes and the organoid risk that we want to spare. We can distribute the dose in a very conform way so that only the top dose, highest dose, is given to the primary tumor volumes, saving as much as possible the normal tissue. We use fancy imaging, fancy delivery machines with onboard imaging to verify on a daily basis that what we do is indeed what we should be irradiated. And now we can use the image which are of poor quality that we can get from the machine. We can improve with AI and do synthetic cone beam CT, which allows us, if necessary, to replan the dose during treatment if there is a need for adaptation. And all of this, I have to say, paid, because if you look at Danish data from 20 years ago, 1985, I should say, even more than 20 years ago, up to now, it has increased substantially. The local regional control probability in the field of head and neck has increased substantially. It's not only the technical evolution. I repeat, it's not only a technical evolution, it's also understanding of the biology, combination with chemo, accelerated radiation, combination in these instances with hypoxic cell sensitizers. But obviously, this improved substantially, I should say significantly, the success of what we can deliver to treat patients today. And so within this context, so I set the scene, I would like to discuss with you that in my opinion, the future will come from 3 ways, or at least not only 3 ways, but at least by definition, I'm a human being, of course. So by definition, I am heavily biased, but even more heavily than you could think of. So what I've decided to cover with you maybe my way, my view on things. It may not be your view on things. You may think this guy is biased. Yes, indeed, I'm extremely biased. I'm sorry to say so. But I do accept my biases. So optimization of radiation dose distribution will clearly, in my opinion, improve the things we will offer to patients. Better integration with surgery. Yes, some patients still do need surgery. We need to interact with each other, and we need to better interact with each other. And it will, again, be for the best of patients. And then, obviously, biological agents can improve what we deliver with ionizing radiation, and maybe combining the two, refining the combinations will help us. All of this, in my opinion, I will exemplify it with head and neck, because that's the only thing I can do from there to there. Below, I don't know. Above, I don't know. I do my best. I'm limited, but I recognize it. But it can be applied. The philosophy, the strategy, in my opinion, can be applied in other diseases, because I understood that we have orthopedic surgeons in the audience, also general surgeons. So obviously, it will also fit your field, gentlemen. Don't be afraid of it. An important aspect that you are always blaming us, rightly so, I have to admit, is that 10 to 15% of our patients that got irradiation quite after 2, 3, or even 4, 5 years or longer will get swallowing difficulties. Swallowing difficulties means bad quality of life, means aspiration, means pneumonia, may means death of the patient. And indeed, we have to learn how to better delineate the target volumes, how to better irradiate or not irradiate it, the structure that are involved in the swallowing functions. And swallowing functions, it's a difficult, complex, you are surgeons, you know it, is a complex movement of different muscles. But one of the muscles which play a key role is a constrictor muscle. And we have learned indeed how to do radiation, sparing the dose to the constrictor muscle, decreasing the dose to the critical organ at risk that may, at the end of the day, impair the adequacy of the treatment we have delivered to patients. And indeed, this trial, which was an English trial, have shown that by sparing the constrictor muscle, you could indeed decrease the toxicity, improve the quality of life of these patients. So the first message is that individualize your normal tissue at risk that are target for late complications, and try as long as you can. Of course, if you have a T52 tumors, there is no way you will be able to spare the constrictor muscles, I guess so, unless it's a laryngeal tumors. Then it can be a T105. You can still spare the upper constrictor muscles. But if you have an oropharyngeal, you will not be able to spare it. But at least try to recognize what are the structures that need to be spared to try to improve to decrease the complication rate and improve the quality of life of patients. It's the matter of recognizing and dose distribution. Along this path, obviously, we may look at different radiation beams to try to use the intrinsic capacity of some of the other beams. By other beams, I mean non-photon beams, not X-ray beams, to try to better irradiate what you need to irradiate without irradiating the normal structures around. And you know, in this institution, because you were the first in India to get proton beams, and obviously it's the way to go because of the fall-off, rapid fall-off and very short fall-off of the dose at the end after the Bragg peak. And if you look at dose distribution, you can clearly see, I don't know if you see my pointer, maybe you will not see it, doesn't matter, that on the left, on the right-hand side with protons, you obviously got a lot of normal structures that were not irradiated, not at all irradiated by the use of protons. And so this may be a way to indeed further decrease the radiation dose to the normal tissue that will give complication. Normally, it should not modify the dose to the target volume, but only decrease the dose to the organ at risk. And this is just another example in a prostate sorry, not, excuse me, that's a psychiatric mistakes. That's really psychiatric or psychoanalytic. There is maybe a psychoanalyst in the audience. I will ask a consultation after the meeting. It's for parotid tumors. Obviously, you can see that in the middle, all what is in green is the saving of the radiation dose to the normal tissue when you compare photons with protons in radiation. And retrospective studies from MD Anderson Cancer Center have shown that by using protons, you could potentially decrease the rate of G-tube dependency and weight loss, again, by decreasing the dose to the swallowing structures that are needed for all the mucosal structures that are involved in these functions. We are lucky. Lastly, we are lucky to get 2 randomized controlled trials exactly asking the question, is protons or are protons indeed able to spare the normal tissue at risk that we consider as important and thus decrease the toxicities and thus improve the quality of life of patients. The first one is the MD Anderson Cancer Center trial, which randomized patients with oropharyngeal. The majority of them were HPV positive, as you know, in the States, but not all of them. I think 95% were HPV positive, 5% were HPV negative. Between IMPT, intensity modulated proton therapy, 70 grays, and IMRT, intensity modulated radiation therapy with photons, similar dose, 70 gray. There are some difficulties with these trials in the sense that, as you may know, as you know, in the United States, if you pay, you get it. If you don't pay, you don't get it. Some patients wanted to get protons and they paid, so they were bifurcated, although they were randomized to photons to protons. So there are 20% of the patients were not exactly treated according to the assignment of the randomization. So obviously, this is something which is unfortunately negative for this trial. Wonderful. First time ever showing that in blue IMPT, in yellow IMRT, the progression-free survival was in favor, although the difference is not really significant, in favor of protons. So this is the first ever published data, randomized control data, showing that yes, when you do treat with protons, you do at least as well in terms of progression-free survival, in terms of efficacy. 42% of the patients needed gastrostomy in the photon group, only 28 in the proton group. I have to admit that 42% of feeding tube in IMRT, it's not my practice, but probably I'm a butcher and not a good radiation oncologist, so I should probably increase my gastrostomy tube dependence, but I was surprised. Anyhow, based on the trial, they indeed statistically significantly reduce the G-tube dependency when they treat with protons compared to photons. And because of that, they showed that the malnourishment and the weight loss was significantly decreased in the proton arm compared to the photon arm, which is for the first time ever a clear demonstration that indeed protons do what they were supposed to do to decrease the normal tissue irradiation, thus improve the quality of life of patients. The British, as you know, they are very critical people, did a similar trial called the torpedo trial, oropharyngeal. The majority, but not all, were HPV positive, but it was a mix between HPV positivity and HPV negativity. And I guess it was 60% HPV positive, 40% HPV negative. They asked a similar question. randomization 2-to-1, IMPT, IMRT, similar dose. Some patients got concomitant chemoradiation, so proton or photon with cisplatin high dose 3 weekly. And the primary objective was exactly the same, to assess whether IMPT compared to IMRT in terms of toxicity. Surprisingly, only 1.7% of the patients treated with IMRT needed a feeding tube. So 20 times more in the US compared to this. You may say, yeah, the British do not have enough resource to put feeding tube. That's maybe an option. It's true that they don't have lots of resource. We know it, especially now that they are not into the European community any longer. It's a double mistake, but still. And clearly the question was differences between photons and protons. No difference in terms of feeding tube dependency. Weight loss. More weight loss observed with protons compared to photons. Please don't ask me why. I cannot explain it. I can really not explain it. And overall, feeding tube or G3 weight loss, a factor of 3, almost a factor of 3, between protons and photons in favor, or in disfavor, I should say, of protons. And indeed, when you use the University of Washington quality of life at 1 year, which was one of the endpoints of the study, they did not find any difference between protons and photons. What do we do? Positive trial on one side of the ocean, negative trial on the other side of the ocean. We wait what will come from the northern people, the Viking. The Viking, the Danes, organize an ongoing randomized phase 3 trials where they use selection of the patients based on dose distribution differences between protons and photons. In other words, they say, I believe this patient might benefit from protons because the dose distribution is in favor of protons. These patients, and only these patients, will be randomized between protons and protons. So you have an enriched population. And maybe in that enriched population, they'll be able to see that indeed what you expect to see, which is lower dose distribution and lower complication rate in the proton group, will get indeed confirmed. We'll have to wait, I'm afraid, until 2027 or 2028 before knowing. In the meantime, because you have protons, what do you do? Of course, I fully understand that if you do a dose distribution differences between proton and photons, and you see that it favors the use of protons, especially for a young patient with oropharyngeal, HPV positive or HPV negative, non-negative, I would definitely also go for protons. But I'm from a poor country. I don't have protons in my country available to me, at least. I'm not talking about the second subject because I know that some of you, or maybe the majority of you, are surgeons. I'm not used to polish the skin of the people, and that's not my way of doing. But I strongly believe that in the field of head and neck, better interaction between surgeons and radiation oncologists will make a key differences for the patients. And so optimize integration with surgery. There is no, as all of you know, and Sarbani Ghosh said so in my introduction when she introduced me, we have published quite a few guidelines for tumor in place, for target volume delineation. We have proposed guidelines for the neck node already more than 10 years ago. We decided that we should also propose guidelines to unify what we do in the post-surgery aspect, based on what the surgeons have done, based on what they would like us to do to complete, to improve the wonderful job they've done by operating the patients. And these two publications came last year. First, what are about the delineation, the selection and the delineation of post-op radiation. This is key. When we do post-op irradiation, we need information that you guys should tell us. We need to have a clear pre-op description of the tumors. We need to know where was the tumor, what was the site, what was the depth of infiltration, what was the laterality, what was the proximity with the midline, and all other structures that we need to know. We need to know exactly what you have done, whether it was a bilateral neck node dissection or unilateral neck node dissection, whether it was in one piece or several pieces. All of this information will play a role in what we do. And we need, of course, the pathologic report, the exact, extremely well-detailed pathologic report, the pattern of infiltration. There was a lecture a few days ago, yesterday or the day before about it, the location, the size, the margin, not R0, R1, because in different parts of the world is differently defined, less than 1 millimeter, more than 5 millimeter for oral cavity, between 1 and 5. Dysplasia, and all these other factors that need to be involved. And then based on that, we will try to complement what we do. We will try to recreate what was the tumors that you resected, guys, or ladies, excuse me. So we will base this on the pre-op imaging. We'll base this on the scarring of the tissue in the post-op setting, either the defect or the muscles that has been put to compensate the defect. And then we'll put margins on it. I will not go into too many details. It's technical aspect for us, which is not of interest. You see on this slide, on A, you see the MR diagnostic. On B, you see post-surgery. And you see on B that post-surgery, we put the pre-op images on the post-surgery CT. And you see in C, the resection cavity, we put margins on it, and then we end up in F with the tissue that we believe is at risk. Only the small part of the tissue which is at risk for post-op radiation, which is slightly different than what we used to do in the past, which was almost to irradiate the full oral cavity. This will maximize the efficacy, hopefully minimize the toxicity, and hopefully improve the quality of life of patients. When you put a flap, and you usually put a flap because it's large tumors, we can recreate the flap and then consider that this was the resection cavity. And then we put margins on the flap and the resection cavity to try to indeed better delineate what we do. Similar example with a T4 invading the mandible, which on B is put on the post-op situation. And then based on what I discussed, we can recreate what was done, what needs to be irradiated to limit the radiation dose, which in that case will be quite extensive. In the neck, we know what you have done. We know what should be done based on the infiltration, the pathological infiltration of lymph nodes. And so we know that we can complement what you have done with what we should do. Especially the question is whether tumor was lateralized or not. And if it's more than 1 cm, it's lateralized, and unilateral treatment can be done. If it's less than 1 cm from the midline, it's maybe not lateralized, and contralateral neck node dissection or irradiation needs to be done properly. We can do the same for the nodes, similar approach. So in this example, there was no nodes visible, but after surgery, it turns to be a PN2B, PN2B in level 2, in level 3. Then these levels in a post-op situation, we get high dose. We will complement the other levels, 1B, 3, 4, and 5, with lower dose of radiation. And in this situation, in this example, the surgeons, for whatever reason, and I don't put any criticism, of course, I'll never criticize surgeons, never ever. Even if I'm 60 plus, I don't do it. We did put radiation on the contralateral side because it was not primarily done. Another example where we see the nodes that you see on A, and then we put margins to be able to properly define what needs to be done. So we believe that this is ways to refine the interaction between disciplines, to limit somehow the non-target tissues that don't need to be irradiated, and further improve the quality of life down the drain of patients. And again, I've shown head and neck because the only thing I can do is the only thing I can do, but it could be the same in breast cancer, in GI cancer, in maybe not in CNS cancer, I don't know. But in other diseases, it can be exactly done similarly. Last, could we optimize radiation with biology? The first time we did combine chemo and radiation, we understood that the way to improve the radiation efficacy, the best way at least to improve the radiation efficacy, by interacting at the DNA level, at the proliferation level, at the apoxic level, at the apoptotic level, was to combine concomitantly radiation with chemo. And indeed, this translated into this big meta-analysis of close to 20,000 patients into a 6-7% overall survival benefit. By the way, guys, 6 to 7%, 6 to 7%, 5 plus 2, limited improvement. So we have to be very modest in what we can achieve these days. But we know, we understood over the last 10, 20 years to understand what we called the immune therapy game changer. And we know that radiation is probably an extremely good way to stimulate the release of tumor antigen, of tumor DNA. And this tumor antigen and tumor DNA could ideally trigger an immune response that could then affect the whole body by releasing the T cells, the killer T cells. We know that by having this concept in mind, logically, yes, I have to say, logically speaking, we said, let's combine immune therapy concomitantly with ionizing radiation or with concomitant chemoradiation. The point was concomitant because we were educated in the field of concomitant chemoradiation is the way to go to potentiate the two or the three modalities. So we did the same. And you know, 4 studies have been published, all negative. This is the first one, the Javelin study. In red is concomitant chemoradiation. I repeat, in red, it's concomitant chemoradiation. In blue is concomitant chemoradiation and avelumab. The difference is not significant, but obviously it's puzzling. And the 2 other studies, the Gore-Tex studies, the 2 Gore-Tex studies, and the 4th studies were also totally negative. Why so? As I mentioned, this magic immunity cycle needs to activate the T cells in the neighboring lymph nodes. So the dendritic cells need to carry on the tumor antigen to the neighboring lymph nodes. But what are these lymph nodes? In the typical way we treat radiation in the field of head and neck, they are killed immediately by ionizing radiation. A low dose will immediately kill them. So maybe there will be no sites for tumor cells or T cells activation. So maybe, on the contrary to chemo, immune therapy combined with radiation should maybe not be concomitant, but maybe deferred in the induction or adjuvant. And indeed, when you look at different fields, in A, in esophageal, in B, esophageal 2, in the lower part for pelvic tumors, we always treat the lymph nodes, the neighboring lymph nodes. So maybe we should revisit the way we combine immune therapy with ionizing radiation. It's not to potentiate, as we do with chemo, ionizing radiation. It's maybe acting in a different way. So maybe we have to dissociate the two. And there was a very nice study, a wonderful study, at least I found it wonderful, a pre-mouse study, They implanted melanoma cell line in the flank or in the axilla of mouse. And then they irradiate the primary tumor and the axilla or the inguinal lymph nodes simultaneously or with time difference. And as you can see on the bottom graph, in the orange curve, they irradiate simultaneously the lymph nodes and the primary tumor. All tumors recur. In the blue curve, they wait a few weeks after the local irradiation to irradiate the lymph nodes. Almost all except one tumors were cured. So the dissociation between local treatment and regional treatment for the nodes make a big difference, and they were able to observe that the number of T cells, CD8 positive T cells, were much higher when they did dissociate the primary tumor irradiation compared to the lymph node irradiation. So I'm afraid we will have to revisit the way we combine chemo and, the way we combine radiation and immune therapy. And in this setting, we set up a phase 3 randomized controlled trial where we did for lateralized head and neck tumors, oropharyngeal, laryngeal, and hypopharyngeal. By lateralized, I mean not reaching the midline, to irradiate unilaterally, maintaining thus the contralateral lymph nodes non-irradiated, plus a modulation with ETRA, all trans-retinoic acid, a modulation of the immune response. And we expect by doing so to be able to show that, yes, by dissociating in a way it's a dissociation, or at least non-irradiating the lymph nodes that does not need to be irradiated, we will preserve the immune cells, the immune actors that are needed to trigger an immune response. And for those of you, we may say, why ETRA? Because ETRA will act on the myelo-derived suppressor cells. They will increase the maturity of these cells, and these cells are in fact anti-immune response. So by doing so, we expect to increase the immune response. And indeed, there are very nice data on mouse showing that if you irradiate and give ETRA at the same time, you'll increase the response at the tumor level. So again, it's an example to show you that combination after proper understanding of ionizing radiation effect and immune therapy could help us to increase the way we treat, increase the efficacy of what we do on a routine basis. So we know this study about neoadjuvant pembro before surgery, after concomitant chemoradiation, which was given after surgery. Maybe this is the way dissociating the radiation with the use of immune therapy is maybe the way to go in the future. I will not speak about this NIVO trial, which was nivolumab given after surgery and concomitant chemoradiation, because there are some issues with this study. I don't want to enter into too many details. Another aspect, which is also quite interesting, to try to better understand and better combine biological aspect and radiation. This is a phase 2 Memorial Sloan Kettering Cancer Center study. We know in the field of radiation that hypoxic cells are much more radiation resistant. Typically, you need 2 or 3 times more radiation dose to kill the same amount of cells. This is a study on oropharyngeal HPV positive patients. Either with an F-MISOS PET scan to detect the presence of tumor hypoxia, there was no hypoxia, or there was reoxygenation and hypoxia disappeared after 2 weeks of treatment. These patients, instead of getting a 70 gray dose, they got half 30 gray. And the one that remain is a phase 2. The one that remain hypoxic, that were hypoxic, that remain hypoxic, they got the 70 gray dose. I mentioned again phase 2, as you see, proof of concept, at least not proof of concept, at least it validates the randomization in a phase 3. It looks like that selection of patients based on the hypoxia, non-hypoxic patients, HPV positive or pharyngeal in the neck, could be as well cured with as low dose as 30 grays, which means less fibrosis, less swallowing difficulties, less dysphagia, and so on and so on and so on. I know that the phase 3 randomized control trial has been started with this concept. So obviously, there are many more concepts in the field of combining radiation with biology that can be started in, and that they will be started in the coming few years. So I tried, my last slide, I tried to give you examples. As I mentioned again, I gave you head and neck examples, but it could be translated into different other tumor sites. That optimization of the radiation dose distribution is certainly a way to either further improve the efficacy, but for sure also decrease the toxicity of ionizing radiation in the field of head and neck, which is a small volumetric area with a lot of complex structures, muscles, nerve, vessels that influence a lot what we do on a routine basis, which is to swallow and to speech, is probably a way to improve the quality of life and the efficacy of patients. Optimization by better selection and by a better delineation of the target volumes, especially if we deal with other disciplines such as surgery, is, in my opinion, certainly a way to go to try to maximize the benefit of the two modalities and, if possible, minimize the risk. And again, this can be done not only on this, should be done not only in the field of head and neck, but also in other fields in oncology. And then optimization of the biological modulation of ionizing radiation, which will come from a better understanding of what radiation does, what other mechanism, other biological factor does, hopefully, and it's not only the field of head and neck, this will allow to also improve. And of course, the three are not competing with each other. The three should be combined. You optimize the dose, you optimize the efficacy, the biological efficacy, and you optimize the relationship between the different fields in the field of oncology. With that, I would like to conclude my lecture. Again, I was really deeply honored by your invitation, and I would like to thank the technical staff because it was a perfect technical, and thank you very much for your kind attention.
Thank you so much, Professor Gregoire, for that remarkable oration. Apart from the wisdom in the slides, I think the clarity, the humor, and just the lightness of the way in which you spoke made this oration very enlightening and I think very engaging even for non-head neck radiologists like me. So we are truly privileged to have heard from you today. You have indeed set a very high benchmark for future orations. To honor your contribution, I invite Dr. Sudeep Gupta to present the oration plaque and scroll, and also request him to read the oration plaque.
It's my honor and privilege to read the plaque. We, the director and staff members of Tata Memorial Center, on the occasion of the 24th annual meeting on evidence-based management of cancers, have the proud privilege and honor of conferring the Hospital Day Oration on Professor Vincent Gregoire, Head of Radiation Oncology, Department Lyon Bernard Cancer Center, Lyon, France. in grateful appreciation of his learned discourse on head and neck radiation oncology in 2026, what can we expect from technical and biological innovation? We note with a sense of immense pride that his scholarly presentation provides profound insight, makes a vital contribution to existing wisdom, and illuminates a path towards welfare of all humankind. We place on record this benevolent gesture of Professor Gregor. Thank you.
And as we approach the end of this prestigious event, unusually before scheduled time, I call upon Dr. C.S. Pramesh to deliver the vote of thanks.
Thank you, Akshay. And it's my pleasant duty to thank everyone responsible for the event, as well as the session that we just recently had. One of the key takeaways for me from Dr. Gregor's oration was the fact that he tried to seamlessly integrate radiation dosing, integrate it with surgery, as well as biological modulation and management of head and neck oncology, which, as he mentioned, is equally applicable to various other cancers as well. And even the theme of the evidence-based management meeting resonates with this. The fact that while we treat an individual patient with the best possible evidence, integration of this evidence with the particular circumstances that an individual patient has, and taking into account the patient's personal values is as important as looking at the evidence itself. So great takeaways from that talk. But equally importantly, I think he stressed on something which may or may not have been picked up by all of us, which was the fact that as human beings, we are all prone to bias. And when it comes to evaluating evidence, I think the more experienced we are, the more knowledgeable we are, the more biased we are as well. And we just recently concluded a meeting or a workshop to create national guidelines for various cancers. And this was demonstrated time and again that we are all inherently biased in the way we view evidence. And one of the key self-realization that we need to have is to actually step back from those biases and evaluate the evidence dispassionately, and to make sure that we offer our patients the best possible care. There are far too many people to thank for the overall organization of this meeting, and apologies in advance if I miss out on any of them. First, the faculty, both national and international, who traveled thousands of kilometers to be with us on these for some 4 days of the workshop, as well as the conference itself. To all of the delegates who are here today, without which a meeting of this nature would not attain the end results that it is supposed to have. The organizing team, and I must particularly congratulate the head and neck disease management group, everyone who worked towards that to ensure that, except for a few technical glitches that we had just at the time of the oration, it went really smoothly, and I expect that it will continue to do so for the next day and a half as well. what I've seen from the meeting yesterday and today has been the fact that it's been a very interactive meeting, and that's what probably is at the heart of whether a meeting is successful or not. In various conferences, you see people being passive listeners rather than interactive, and often very considerably could be considered as argumentative. But nevertheless, I think that brings in the element of engagement with the audience, and I saw that in ample demonstration over the last 2 days. Again, thank you to the CRS team, the DAE Clinical Trials Center, which was part of the organizing team, and for all the efforts that they've put in. But I would also like to take this opportunity to acknowledge the fact that this meeting started in 2002, when the concept of evidence-based medicine was actually coming in anywhere in the world. And I must take this opportunity to thank Dr. Badwe, who conceptualized the meeting way ahead of our time. And it's a true testament to the vision that he had, that we continue to do this year on year. And next year will be our 25th evidence-based management meeting, which we hope we will continue to change as we go ahead with the times. I'd like to also take this opportunity to thank the administration of the Tata Memorial Center, all the people who worked behind the scenes to make sure that things went on smoothly, and very grateful to all of you. And it's again my pleasant duty to inform you that no one is standing between you and lunch now. And I'll invite all of you to go up to the 4th floor or to the cafeteria on the 2nd floor of the service block, where we will have lunch now. Thank you all very much for your kind attention.